So although this is a comprehensive course about lamellar keratoplasty techniques, but I think we're just offering a lot of everything and trying to convince the audience of which procedures to adopt. So I'll be talking about ultra-thin DSAEK. When I was preparing this presentation, I thought of talking about everything you need to know, but I'm sure that all the audience or the attendees, they know more of DSAEK than myself, actually. So I chose to talk about how to make your ultra-thin DSAEK easy. And I have no financial interest in this talk. Why ultra-thin? Because we wanted to combine the best of two worlds. The world of DMAEK and its superior results, the clarity, the fast visual rehabilitation, the lower rate of graft rejection, but we wanted also ease of preparation and surgical handling of the graft with less going to the theater for rebubbling. And although we talked a lot of endothelial surgical procedures, DSAEK is still the #1 technique for endothelial keratoplasty worldwide, not because it is a superior surgery, no, but because you can perform this kind of surgery on very complex and complicated eyes. So again, why ultra-thin? Because we wanted to have a lesser learning curve, and we're comparing it with DMAEK. We want less graft manipulation, we want less rate of graft dislocation, and we want less wastage of tissue. On the other hand, we wanted a speed of visual recovery that is fast enough, less hyperepic shift that we see with the traditional DSAEK, more than with visual rehabilitation that we see with DMAEK, less peripheral anterior synechia, more cases of 20/20 vision that the DMAEK offers us, and less cases of endothelial rejection. And so how could you accommodate DMAEK while performing DSAEK? The concept of ultra-thin DSAEK came out. And if DSAEK is more than 130 microns and DMAEK was between 14 and 20 microns thick, DSAEK, ultra-thin DSAEK is less than 100 micron. And now we're dealing with the concept of a nano-thin graft, which is almost 50 or less micron thick. Who are your candidates? Just going back, reviewing our basics. Any patient with a corneal decompensation or edema can be a candidate. A Fuchs dystrophy, a pseudophakic bullous keratopathy, and these are the most common cases. A failed penetrating keratoplasty, a patient with a tube or a trap and endothelial decompensation, but you have to tie the tube. Don't forget that for airfill. Congenital hereditary endothelial dystrophy, ICE syndrome, trauma causing endothelial decompensation, and posterior polymorphous corneal dystrophy. All these cases are good candidates for ultra-thin DSAEK. It's actually the same as DSAEK. In comparison to DMAEK, that you need a good visualization of the AC and an intact posterior capsule. So it's contraindicated in cases where there's severe stroma scarring, if there's vascularization, if there's vitreous in the AC that will interfere with attachment, if you have peripheral anterior synechia, if the thickness is above 1300, also it's a contraindication, and if you have a shallow AC. And all these contraindications are because they impede the attachment of the graft and they impede the clarity of the stroma of the cornea. Now, before you attempt your graft, whether it's a DSAEK or an ultra-thin DSAEK, you should check the status of the lens. Is it phakic, aphakic, or pseudophakic? And note if it's stable or not, because the air frill, if it's not stable, it might just fall posteriorly. And the iris status is important. If there's a large PI, as Professor Agarwal has shown us in his videos, you have to make it smaller in order to maintain air in the AC. The pupil also, you have to note the size of the pupil, if does it dilate or not, if there are seclusive papillae, if there are vessels, if the iris is atrophied, or if it bellows during surgical procedure. It's important also to obtain an OCT before surgery because you want to see the interface that you're working on. And these two photos, they show an OCT, an anterior OCT of a patient who underwent a PKP 20 years ago and that failed. And after that, he underwent a DSAEK that also failed because it did not attach. And when he came to me, I saw that the problem with the DSAEK attachment is that it's there's a rough surface posteriorly that the interface of his PK graft was not uniform enough. So what I did first, I revised the scar of his old PK. And as you can see up on the corner of the slide, the old one, you can see a pocket of fluid at the interface between the DSAEK graft and his PK. So I just dissected it open, and I revised and resutured the graft again. And when I attached the DSAEK graft, it just uniformly attached, as you can see in the lower part. So this is a very important aspect. Now, I'm going to go quickly through the classical graft preparation of DSAEK, which is similar to ultra-thin DSAEK. Now, we have two options for the surgeon. You either import a pre-cut tissue if you don't have available tissue, or if you have an available tissue and the instruments around you, you can fashion it in the operating theater. And I am an advocate of fashioning a fresh graft in theater because I control all my parameters. So what you do, you mount it on a corneal sclera button on an artificial anterior chamber. What we have is the Moria CBM. And then you remove the epithelium using a sponge, and you control the bottle height of the infusion, and you clamp it near the entrance to 200 millimeter mercury. And then after you measure the pressure and the thickness of the cornea, you slice it actually with a microkeratome blade around 350 micron cut. So this is the classical DSAEK. How does the ultra-thin DSAEK differ? Only in one step, which is the cut is deeper. And it is explained in two ways. Boson described in 2009 a way of getting a very thin graft, which is by passing two heads of microkeratome in opposite directions. Usually it's a 200 micrometer head, and this is because you get a planar surface of the cornea. And there's the other way of getting a very thin corneal graft for ultra-thin DSAEK is by debulking it, by taking out like 350 micron or 400 micron thin, and then checking the phacometry and refining it with another step. And I have been using either of these ways, but recently I have adopted a new technique for getting an ultra-thin DSAEK, saving time in the operating theater and getting more reproducible results and without perforations, and which is the alcohol thinning technique that was described by Romano in 2017. So what I do, I only need one head of the Moria microkeratome, which is the 350 head, and I thin the cornea, whatever is its original thickness, down to 500 microns. And this is by placing alcohol and drying it until it reaches around 500 micron thickness, and then passing the microkeratome blade on top of it. So I just want to go quickly over this video. Just shows you how you perform the drying. So I do it for 60 seconds, and then I wait and I measure the thickness of the cornea. And it's very important that you do not exceed 5 minutes under extreme pressure, intra-chamber pressure, because this will damage the endothelium. So I do it only for 3 or 4 minutes. Every 60 seconds, I check the phacometry that I get. And once I reach around 500 microns, that would be okay for me. I don't advocate going below 500 microns because it gives you a deeper cut, and there's the risk of perforation. And so as down as you go to 506, 507 is just very good and ideal. So when you reach the desired thickness, you can just do your cut. And it's very important that you go slowly over 20 seconds of fashioning the cut. So in order to save time, you have to make sure that all the instruments around you is correct and in position so as you don't risk the endothelium of the graft. So you fashion it and you pass the blade, as you can see, and I like to use saline as I pass the microkeratome blade very slowly over 20 seconds in order to maintain a regularity of the surface and also to get a very deep cut, which leaves me with a thin graft. How effective is this? It's very effective. This is a study that we made last year and we presented in ECHO, and these are a few patients that we've started with a thickness like around 550, and then the thinning time took 3 to 4 minutes, and the pre-cut thickness went down to a maximum of 510, and we've got ultra thin grafts of like 90 and 85, and the 1 month post-op we could get nano thin thicknesses. Now this is a video showing the procedure. I just want to share a few tips in my technique. First of all, we fill the anterior chamber with air. This is the classical teaching. When I do the endothelial scoring using the reverse Sinskey hook, and I outline the cornea without using ink because it interferes with my vision, I use the reverse Sinskey hook by just touching the endothelium. I do not try to deeply touch the stroma, because if you score so vigorously and deeply, you will tuck in the decimate membrane into the stroma, and you will leave tags, and it will make it hard for you to just detach it. So this is an 8 millimeter in the diameter graft. I just scored it so lightly, and I try to pull the scored graft to the center. To make sure that there are no tags left behind, and it just peels so easily. As you can see, I just bring it all in the center, and then I take it out as one piece. And it comes out as one piece. After that, I use the AC maintainer. It's very important that when you use the AC maintainer that you don't put it vertically, use it diagonally, because first of all, so that it does not interfere with the placement of the graft, and it does not get stuck and carcerated with the iris. And I fashion my wounds at 10 and 2 o'clock position. This is a 4 millimeter wound, and I make sure that it can accommodate the boosting glide that I use for graft insertion. And then I go and spend the time refining the graft. The graft is, what I like to use is the Boosin punch from Moria. There are many kinds of punches that you can use, but this kind of punches give me a good visualization of the graft. So I punch it, and I make sure that I spin the corneoscleral rim that's in the outside and the skirt to make sure that there's complete trephination. And I also use BSS on the center to make the central part heavier than the peripheral part, so as when I pull out my graft, the trephine, it does not pull the ultra-thin graft with it, because sometimes it gets stuck in the between the blades of the trephine. And after that, I just put it in I move it in the boosting glide. There are a lot of ways in order to insert your graft in the eye. So what I like to do is the pull-through technique, bimanual technique described by Boosin using a forceps. So this is Boosin spatula with a glide. As you can see, the ultra-thin cornea is very thin, that it floats over the fluid. I don't touch it at all. I just scoop it with the glide. And as you can see now, as I float it, I put extra fluid, and I rotate, and it just floats on the spatula for me without needing to touch it. The more I minimize to touch the graft, the less endothelial cells I lose. And this is what I want, actually, in my surgery. And then I move to loading it onto the spatula, just using a reverse Sinskey I just push it from the stromal side, or a cannula. Graft insertion techniques, as I said, there are a lot of techniques to insert the graft. You can use a forceps and the glide pull-through. There's a suture pull-through. You can use a tan endoglide, or there's a Boosin endoglide also. A sheet glide, this was used usually for the DSAEK to place a shield with a larger corneal wound. And there's an endosaver way of inserting a wheel of inserting the cornea in the AC. One of the things that I just want quickly to go through the tips over a good insertion. As I said, place the wounds over the 10 and your side ports on 10 and 2 o'clock position. Why? Because you make it shorter distance for the graft to travel. And if the patient is phakic and you want to preserve the lens and not remove it, you protect it from being injured during the surgery. The second thing is that when you use the AC maintainer to push the graft. Let me just go back to the previous video. Yeah, I just want to show how we insert the graft. Okay, yeah, one of the very important tips that when you insert the graft, you need to keep the AC maintainer in, and I make sure that my forceps is out on the outside, and I pull both the glide and the forceps in the AC together. Now, if you can notice what happened here, it just slipped out of my forceps because I just gave a push of BSS from the AC maintainer before I could get it all through in the eye. So first, you don't let go of the forceps in your hand unless you check the orientation of the graft that it is okay, and then you put a little bit of an air bubble under it, and you remove and entangle the AC maintainer. And then you move to before filling it with air. It's good to centralize it by just tapping it to the direction you want it to be. And then you fill it with air. There are two schools. What I do, and I find it very comfortable, and is that I fill the air with air, the AC with air for 40 minutes, 100% fill. It's not rock hard, and I use the time to instill dilating drops so that I don't get pupillary block, and I just close the wounds and talk to the patient, and we spend some relaxing time until I make sure that the patient, the graft is in its place. And after 40 minutes, I just deflate it to 80% fill, and I keep the patient in the recovery room for 1 hour on his back. I check his intraocular pressure, I check the air fill, and I check the attachment of the graft, and I discharge him to be seen next day and give him direction to lysopine 24 hours to make sure that the graft is in place and does not detach. Again, why ultra-thin? As we said, it's a fast visual recovery. The ultra-thin DSAEK gives the same as DMAEK percentage of patients reaching 20/20. There's minimal hyperopic shift because there's a minimal increase in the total corneal refractive power, and the postoperative endothelial cell count is comparable, if not better, in ultra-thin DSAEK than DMAEK. And as I said, it can be done mostly in complex eyes, but giving us superior results. Thank you very much for being with me, and this is a thank you from my team at King Hassan Medical Center.
That was excellent, really. Thank you very much indeed.